Good afternoon. Andy McMahon. I'm a principal with Health Management Associates, and we are a healthcare consulting firm focused pretty much entirely on public healthcare, Medicaid, Medicare, and some duals work, and have been around for about 40 years with somewhere around 1,000 folks across the country doing great work with health systems, with payers, with providers, and the like, and delighted to join all of you guys today at this conference at SOCAP to talk about how we can work and how health systems and payers and providers and others can leverage their own balance sheets to make impact investments. And so we are delighted to have three amazing panelists here today. So I will introduce them briefly. But just so you guys know, the kind of quick run of show is that I'm going to mention kind of just a couple remarks at the beginning, then I'm going to have Pablo talk from kind of a healthcare investment perspective, and then we have two amazing folks who I'll introduce who are going to talk about their amazing work and how it ties into healthcare and where there's opportunities for the healthcare system to engage more broadly. So with us today, to my right is Gina Klein. She's the founder and lead partner for Enable Ventures, which is an amazing organization that is helping to finance a whole host of products and services that support the disability community and work and support efforts to get more folks in the disability community back to work and doing the things that they want to do with their life. So she will share more about that. To my immediate left is Nina, and she is a partner and director with Catalyst Opportunity Funds. Also does some amazing work. We did this intentionally. You'll see two very different potential ways of thinking about investment and healthcare value and the like. But Catalyst does some just incredible work building affordable housing, building community infrastructure and the like in communities across the country, a lot of whom that have been heavily divested in over the course of not years, but decades, and I think you could probably easily argue centuries. And then last but not least is Pablo Bravo, who most recently headed up all of the community investment work during his time at Common Spirit, which he'll probably mention a little bit about, but a large healthcare system with providers and hospitals and clinics and the like all across the country. So as we kick this off, the idea as we were all kind of talking was to lay the landscape for you all in terms of kind of why might folks in the healthcare sector, why might healthcare stakeholders from providers to health systems to payers in managed care be interested and attracted to making impact investments. And so Pablo is going to lead us off in talking through some of that work. And then we're going to turn to Nina, who's going to talk some, okay, if you're interested and you're interested, what are the types of things and where might healthcare be able to find strong partners? And then we'll have Gina talk some about Enable Ventures, and then we will open it up for Q&A, and then thank everyone for their undying commitment to making it till the end of the very end. Although there is some sort of party and reception and final thing, right? So make sure you attend that as well. And I'll probably kind of chime in with a couple of thoughts as we go through. But without further ado, I'm going to go ahead and turn it over to Mr. Pablo Bravo to talk about kind of the healthcare perspective on impact investing.
Thanks, Andy. It's a pleasure to be here. So how many people here are from San Francisco? At least two. Okay. The rest of you, welcome to the city. Enjoy this incredible weather. We have not seen this weather in a long time. How many people here are in the healthcare industry? Okay, so how many are just in investors? Okay, so we have a mixture. Well, thank you for coming to the group. I'm going to try to share with you my kind of roadmap of where I have been for the past 18 years working inside one of the largest healthcare provider in the country. So I was in charge of community health, and within community health, we had this incredible tool, which we call community investment, which was a PRI or MRI, some folks call it. And it program-related investment or mission-related investment, depends where you sit. We called it community investing, basically making loans, low-interest loans to the community. And I was grateful enough to work for an organization that took a percentage of their unrestricted funds and allowed community health individuals to invest in the community. But it wasn't just, it was up to us to invest it, but it was up to us to invest it wisely. So 5% of the portfolio was significant. We're talking about in the hundreds of millions of dollars. By the time I left, we had deployed over 400 million. The way we looked at, from a healthcare perspective, was both upstream and downstream. Looking at upstream, we looked at our community health needs assessment. We looked at the communities based on a need on zip codes to try to see where we can plant or where we can invest to move the needle a little bit further, more than we could with the community benefit dollars, such as grants, et cetera, but really get underneath the infrastructure of these zip codes or communities. Where we identified was housing was definitely a priority. Ownership, low-income housing, assisted living, et cetera, the whole spectrum. Food was another one. So we looked at the social determinants of health based on those zip codes. And we tried to identify projects that we can invest in those areas. We were very successful in a lot of places. In a lot of places, it just took a very long time to get to the level of potentially taking on an investment or moving a project forward. San Bernardino was a disaster, but it finally took off. So that's more upstream, trying to identify areas where, like for example, investing in federally qualified healthcare centers in an effort to avoid that inappropriate hospital visit was key. We found that investing in these clinics was sort of protecting the castle from the outside world from being stormed into the emergency department. Therefore, downstream, the organization could really benefit a little bit from these investments and reduce the costs. Same thing with housing and food. And with food, we looked at the producers and the distributors and the wholesale in an effort, again, to address the food insecurities of those communities because, again, all these have an impact on your health. Going downstream back into the facilities, when we looked at the facility, where were the biggest pain points that we could invest in that potentially could benefit the organization to stay financially healthy? I mean, hospitals are not, even though everybody thinks hospitals make tons and tons of money, and actually a lot of the hospitals are major losers of money. But anyway, so we won't go into that one. So when we were looking at what the impact could be of an investment, a community investment into the hospital, we started looking at the pain points. So one pain point that I can think of is the length of stay. And the length of stay is impacted a lot by homelessness. So one of the things that we thought about investing, and we started doing quite a bit and did more, was to look at respite care, recuperative care. How to invest in those areas that would ultimately take the individual that's well enough to leave the hospital but not well enough to go back to the street. So respite care was that area where it could definitely help stabilize the individual and avoid that readmission, because that's really, and reduce the length of stay. But there's a bottleneck in respite care. You know, you can only put so many people in respite care. Sooner or later, they need to leave. And the option is go back to the street, and unless the respite care has a way to incorporate housing. So the next stage that we thought about is, and we work with a housing developer, is to invest in scattered housing. So we place money in this housing provider, and we bought some properties within town, some homes. And those became like a co-op living scenario. So there was money being generated by individuals because they could draw down either some kind of rental assistance, et cetera, to pay for the services. So therefore, that money that was paid to the provider ultimately could actually pay the loan. So the scattered housing provided a gateway for people who were ready to leave the respite care and wanted to continue to get some kind of housing into these into these scattered housing sites. And again, those were only temporary sites, so you would have to also invest in other kind of housing, and that's longer term. But at least you had a way to move the pendulum a little bit and really avoid that readmission by these individuals. The other area is really what I mentioned before, was investing in a federally qualified healthcare center. And the expansion into creating new centers was really a major piece. I think we were one of the first ones who really thought about investing in FQHC before the community development financial institutions thought, oh, this is a great deal, and it's a great safety investment. So those pain points led to us to look for ways to invest wisely to be able to reduce this risk.
Awesome. So can you talk? Sorry, guys. Can you
can you
talk a little bit? And I don't want to necessarily kind of go into total weeds on the financing piece, but in particular, as you think about the food system and the FQHCs, just to give folks a flavor of like both scale, like if you invested $1 million or $5 million, and kind of, you know, the roughly speaking, kind of some of the terms of that, right? So I'm guessing you weren't earning 0%, but you probably weren't earning 21% either. And just some of the broad parameters of kind of how you thought about the financing component of those investments.
Sure. I'll start from, so when Treasury would hand over us the amount of money, there was guidelines that we put together that the overall, all the loans would be considered a portfolio. So the portfolio had to meet a 3-year average CPI. So now it's, you know, it got to a point where it was really hard to get because CPI really skyrocketed. But in good times, we over exceeded the benchmark. So within that portfolio, we had buckets that we would invest, which is food, et cetera. The range of loans ranged from $500,000 to $15 to $20 million. So we did significant projects. The way we built the portfolio was to the foundation of the portfolio to be able to stabilize and to be able to kind of manage the interest rate. We started looking at CDFIs, Community Development Financial Institutions, as a way to stabilize, to build the foundation, a solid foundation. From there, we began to do direct loans. But on the housing front, we did from $1 million to $5 million on a specific project. We focused a lot on pre-development. Pre-development loans are, some folks would think that they're the riskiest. But when you're partnering with organizations like Mercy Housing or Abode Community or other housing developer, a pre-development loan, it's not that risky for these organizations because you know that there's a significant planning. So some of those pre-development loans will become from $1 million to $2 million. We also were part of our capital stack for either for a construction. We were not the lead. We would never take the lead on these projects because we did not want to oversee the construction. So we were just part of the capital stack. In that capital stack could be between 1 million up to 10 or 15 million. We actually, for housing, we went up to 15 years to be able to give the construction enough room to be flexible. So those are the size of the loans, and it varies. Some of the smaller loans, they were brought to us by some religious. Some of our sisters would have a project in mind, and they'd say, "Here's a, $50,000 loan for somebody's roof. Could we do it?" And it's like, "Sure, why not?" But in the interest rate were from 0 to 5. We did a lot of partnerships with other organizations where we were not the lead. We were actually brought a few banks came to us to say, "Hey, we would love to have you participate. We're making a loan for this X, let's say at 6%. We would come in at 4 or 4.5, a little lower, just to bring the cost of capital lower. But it also helped the portfolio meet that 3-year average CPI, so I can give other folks either a 0 or a 2 or whatever percent. The other, we had the flexibility because a lot of these programs that you invest, a lot of organizations that you invest will have hiccups, and you will have to manage these loans sometimes a little bit. So you play around with the interest rate. So for example, if you have a loan to an organization A for $1 million at 3%, and they all of a sudden they're having this difficult moment of cash flow, et cetera, you could actually play with not only with the payment structure, but also with the interest. Say, okay, well, you know what? I'll forgive the interest for the next 6 months. Just get your house in order. Or you won't have to pay me 3%. You can pay me 1.5%. And, you can play around. So the flexibility of the capital was really great.
Awesome. No, great. Thank you. And before I turn to you, Nina, thank you, Pablo, for saying a little bit deeper there, because I think, one of the things that I think it's important for folks to understand, a few key things, at least from my experience and perspective. One is that these things are very scalable, right? So you could do a $50 million project. You could do a $500,000 working capital, revolving loan fund. And so as you think about either whether you're somebody seeking investment or you're an investor, that the opportunity is there to kind of find investments that fit within both the size of your investment portfolio and within that portfolio, the amount of resources that you may be interested in dedicating to that, so it's very scalable. And also notably, I think Pablo mentioned, right, I think a lot of times when a number of investor types think about investing in affordable housing or clinics or food initiatives or other, they think it's going to be super risky, quote unquote. And so I think there's a lot of work to be done that Pablo and others are doing to kind of debunk some of the risk around there. One, to note that by and large, the risk is, from a risk-adjusted perspective, pretty low. And then also there's a whole host of things, and these folks have talked about this too, as we think about how do you mitigate the risk that does exist, right? So you're probably not going to come in with zero risk, but understanding that there's an opportunity to do that. And then the other thing I would just flag that Pablo mentioned is that, as you think about it, again, whether you're somebody seeking capital or looking to invest capital, that, as I understand it, and having had the good fortune of working with Pablo in the past, right, Common Spirit was able to make these investments in things that aligned with their mission, for one, that aligned and had kind of a business value proposition, right, as you talked about kind of the FQs being the front door part, or trying to limit necessarily the number of people who are kind of descending on the hospital system, and that there's low risk and you can get a modest to good return and sometimes market return on the investments that you're making. So appreciate those comments a lot, Pablo. So
if I can just add
yes,
one
please.
more thing. One thing that I learned was that you can invest in a nonprofit, and the nonprofit may have difficulties, but the nonprofit is not going to pack up and leave town. Unlike investing in a business, whether it's a Lowe's or Home Depot, you give them all these tax breaks, you make this huge investment, but when the times are hard, they'll say, see ya. A nonprofit will stick it out. So if you work with the nonprofit, they will pay back. And that's what I've learned.
Great, thanks. All right, so we're going to shift gears a little bit now and welcome thoughts and comments. I know I have some friends from United, so please jump in as we're in the discussion part. But now we're going to shift a little bit and talk to a couple of folks, and Nina first, who both are doing some, most importantly, amazing work in terms of making investments in communities, strengthening infrastructure in communities, expanding the supply and availability of affordable housing in communities, but also I think it's been really intentional and strategic in thinking about where and how they can attract health system investors. So I'm going to turn it to you.
Thank you, Andy. So I'm Nina. I'm a director at Catalyst Opportunity Funds, and Catalyst is an impact-oriented real estate investment firm with about $1.3 billion worth of community-driven, impactful real estate across the U.S. And the firm was founded in 2018 really as a kind of market rate return-oriented solution to the nation's affordable housing crisis, which was picking up steam then and has really ballooned into a real crisis today. And how we do that is we provide LP equity capital to developers who are either building new housing or preserving existing affordable and workforce housing in their communities. And we predominantly focus on housing for the missing middle. So households earning 60 to 80% of the area median income. These are working households who earn too much to qualify for federally subsidized housing, but who are really being squeezed by rising housing costs in high growth markets. So it's really the teachers, the nurses, the firefighters, the bank tellers, really the backbone of the American workforce that's increasingly being priced out of the communities that they work in and grew up in. And the reason I'm on this panel, I think, is because housing and health are inextricably linked, right? When families are stably housed at rents that they can afford, there are direct health outcomes associated with that. People stay out of emergency rooms. They better manage their chronic health conditions. There's less stress. There are fewer mental health crises. And I'll maybe dive into that a little bit further in a minute. But I think, what's interesting about Catalyst is we're not kind of just focused on providing a stable place to live. We're really focused on building kind of more broadly the community infrastructure that supports health at a number of different levels. So in addition to reducing housing cost burden through affordable rents, which, housing cost burden really forces households to make impossible choices between meeting their rent that month or other important line items in their budget, like healthcare or healthy food, right? But in addition to providing affordable rents to our residents, we're also focused on investments in urban areas. So providing housing options that allow low to moderate income families housing in close proximity to job centers, right? Which also has a direct link to health and certainly well-being. And then lastly, our projects typically have ground floor commercial spaces because, again, we're investing in urban areas, and we're able to take a really thoughtful approach to programming those spaces and program them with tenants that have kind of community health at the center of what they do. And so in one case in particular, and I'll walk through this in my case study, actually providing a health clinic in our ground floor commercial space. So we really think of our work as addressing health, as addressing health equity, as addressing the social drivers of health through this kind of tiered, multi-layered approach and through the locus of our real estate. And we're able to do that at scale. We're institutional investors deploying meaningful capital across the U.S. into dozens of projects. And our LP base consists of a number of healthcare institutions that are really thoughtful and really believe in looking upstream in communities and investing in upstream health factors and drivers like housing and community infrastructure as a way of having downstream impacts on health. And we're really grateful to partner with those organizations. How I thought I would kind of structure the rest of my remarks is I wanted to take a quick minute to just set the stage on the housing affordability crisis and how that impacts health in America. Then I thought I would quickly touch on a case study from our portfolio. Case studies always help me to kind of ground myself in kind of the reality of what's happening on the ground.
It's actually happening.
Yeah, exactly. And then because I'm an IMM nerd a bit, I thought I'd touch on how we're tracking and measuring health in our investments and in our communities. So starting with the housing crisis. So the firm was started 7 or 8 years ago. And at that time, the housing crisis was really a coastal problem centered in kind of urban mega cities like San Francisco, like New York, where I'm from. But over the past 5 or so years, that's really changed. And it's now become a problem that really every city across the US is grappling with, and in a big way. And I think, the crisis has ballooned over the past 5 or so years, I think due to a number of factors, but kind of the two main drivers that I'll point to are, number one, there's a supply-demand imbalance. So Brookings estimates a 4.9 unit shortage of available and affordable housing. I actually think that's kind of a conservative estimate, but there's simply not enough housing to meet demand. And on top of that, between 2019 and 2021, as one kind of data point, 36 states lost more than 10% of their existing affordable housing as those buildings were bought up by investors, and essentially those units were marked up to market rate. And then, the third kind of sub-bullet there is that it's become incredibly difficult to make affordable housing pencil right now between high interest rates, high construction costs, high expense growth. And so there's an undersupply of housing. We're actively losing affordable housing by the year, and then there's not enough affordable housing being built. So really, we're not chipping away at the deficit that we have. It's actually a growing deficit. The other driver that I'll quickly touch on is that rent increases are outpacing income gains, and by a lot. So the stat there is between 1985 and 2020, so over a period of about 35 years, rents rose about 4 times faster and more than incomes. So rents grows by 149%, while overall income grew just by 35%. So that's really forcing Americans to move to subpar, cheaper units or spend kind of a disproportionate portion of their income on housing. And what that's resulted in is a nation that is severely rent burdened, right? So Harvard puts out a report every year, the Joint Center of Housing Studies, and their 2025 report found that over 50% of renters are rent burdened, which means that they spend more than 30% of their income on housing related costs. And of those households, of that 22.6 million kind of households across the US, about 30% of them are severely rent burdened, which means that they spend more than 50% of their income on housing. And if you are rent burdened, that forces you to make really painful decisions about, are you paying rent again, or are you otherwise able to afford healthy food or healthcare, right? And according to this consumer expenditure survey, households that are severely rent burdened make meaningful trade-offs on both food and healthcare. So they spend or cut food budgets by 39% and healthcare expenses by 42%. So, as housing costs increase, as they gobble up more of kind of an inelastic budget, right? Kind of downward pressure forces families to make really painful trade-offs on things that impact health and quality of life. And, unsurprisingly, rent burden has a significant and direct impact on both physical health, but also mental health, of course, obviously also financial health. So rent-burdened households have worse self-reported health conditions and mental health, higher rates of obesity, increased hospitalizations, a higher likelihood of postponing medical services as a result of financial kind of constraints. But the other interesting thing is that rent burden has also pushed many households kind of away from urban job centers, kind of to the periphery of cities, and that's resulted in higher commute times. And higher commute times also is really damaging to both physical and mental health. So if you spend an hour more each day, kind of the more time you spend in your car, an hour more, increases your likelihood of obesity by 6%. And then, of course, longer commutes result in lower job satisfaction, less enjoyment of leisure activities, lower overall life and well-being satisfaction. So, I think at Catalyst, we talk a lot about housing affordability, and that is the core of what we do, right? But it's not the end goal. The end goal is to, give people more disposable income as a result of our affordable rents, as a result of them not having an outsized proportion of their monthly budget being kind of allocated to rent. And through unlocking additional disposable income, having them be able to unlock, improved health, physical, mental, financial health outcomes. And I think in addition to that, by providing housing that is affordable to low to moderate income households and in urban centers near jobs, we're also giving people more time because they're commuting less, right? And they can allocate that time to things that improve their health, whether that's spending 30 minutes, going for a jog, or taking 30 minutes that they now have to actually go to the grocery store, buy some food, and cook a healthy meal versus ordering takeout. So I wanted to quickly run through a case study that hopefully brings our strategy and our kind of thesis on health to life a bit more. And it's one of my favorite case studies to talk through. It's a project called Metropolitan Village, and it's in East Winston-Salem. It's a 198-unit affordable and workforce housing project. And it includes 13,000 square feet of ground floor commercial space. And it's located in a low to moderate income, historically Black community, which was redlined in the 1930s. And in the 1940s, the government built a 6-lane highway through the middle of Winston-Salem that split the city along racial lines. And it essentially separated East Winston from the city's economic center. And the impact of that highway has persisted. So over the past 20 years, the west side of the highway, so the kind of urban core, has received about $2 billion worth of private investment, whereas East Winston-Salem, which is where our project is, in 40 years, so double the time, has received only $7 million worth of investment. So 0.7% the amount of investment as downtown Winston-Salem, despite East Winston being only a 10-minute walk to downtown. And so the developer that we partnered with there designed Metropolitan Village as part of a redevelopment plan for East Winston that was very much so community-led. It came to fruition through a kind of coalition of community stakeholders, including Atrium Health, which is the local health or hospital network there that's also a co-investor in the project. And also the local church. So the local church, which is a kind of East Winston-Salem community pillar, which initiated the project and actually contributed the land for the project at a very low land basis. And what we did is we tore down old, dilapidated housing that was literally falling apart. Had like tiny little windows with bars on them, low ceilings, kind of looked like little prison blocks. And we tore down that housing and we temporarily relocated the residents to a housing complex nearby. And we built our project. And it provides new affordable housing to the community. And once the first building delivered, so our project includes 4 different buildings. So once the first building delivered, we moved families from the old housing into the new housing and brought them in at the same exact rent that they were paying in the prior housing. So that's housing that is affordable to people making below 30% of the area median income. And what that translates to is about $450 for a 2-bedroom, 2-bathroom unit with an in-unit washer dryer. So about 15% of the units were priced below 30% of the area median income, and then over half were priced below 80% of the area median income. So really targeting that workforce demographic that's core to our thesis. In addition to affordable housing, we addressed the neighborhood's core service and amenity gaps, and specifically healthcare need, through bringing in Wake Forest's Maya Angelou Center for Health Equity. So Wake Forest is the university down there, and Maya Angelou was a professor. And she was really committed to reducing health disparity for Black and Brown communities. And so she founded this center in 2002. And when the center found out about our project, they, immediately knew that they wanted to be in our ground floor space. They wanted to be in the community that they were serving. And so Maya Angelou's center, it aims to promote health equity through research, through education and training, through health literacy, through preventative healthcare services, as well as social justice initiatives. So the space is really interesting and cool. It has a service navigation hub. It has treatment rooms, private care treatment rooms. It has a fitness center and a yoga studio. It has a community convening space for education and community engagement. And so this case study, I think, really addresses, again, health in the three primary ways that we think about it, which is, reducing cost burden via our affordable rents, which again, rents that don't force households to make painful trade-offs between making rent and other important household priorities, through close proximity to downtown, to jobs, to services, to economic opportunity, reducing commute times, and then directly supporting health through our ground floor space and programming it with a health equity center. And that's the opportunity that we see with healthcare partners, aligning capital with infrastructure that actually creates healthier communities on kind of multiple levels, right? And we are reporting, I think, on that in some really, for me at least, really exciting and innovative ways. So last year, we implemented a resident survey across all of our operating assets. And that survey allows Catalyst to understand and really report on the impact our projects have on the actual people living in our buildings, right? It is really important for us to move beyond just reporting the dollars invested or the number of affordable units that we've created, which are both really important metrics, right? But they don't tell you anything about the lived experience of the residents in our building or about how we're impacting their health, right? And so we really moved beyond that to report on things like the percentage of households that have more disposable income as a result of living in our buildings, or the percentage of households who have reduced their commute times as a result of moving into our buildings, or have improved their mental or physical health. And I think all of that is a really important way of us assessing our theory of change, right? Are our projects actually playing out in people's lives in the way that we intend for them to? And the results that we got back were really very exciting. So what we found is that 72% of residents maintained or grew their disposable income as a result of living in our building. 74% used that additional disposable income to either save or invest, so to build wealth, right? Which is a really, I think, significant impact on, the financial health and economic mobility of these populations. 72% of residents used that additional disposable income to improve their physical or mental health through things like purchasing healthier food or purchasing healthcare when they didn't have healthcare. And then 73% of residents had shorter commutes as a result of living in our buildings. And 54% of those residents used their free time as a result of those shorter commutes to improve their mental or physical health through things like exercising, important for physical health, or through things like relaxing or pursuing a hobby or things that are really good for your mental health. And so if you aggregate those kind of health metrics, 80% of our residents improve their health through living in our buildings, which again is just a really meaningful data point for us to be able to report on. And, we're not kind of waiting years to see data on how we're moving the dial on health in the populations we're served. We're measuring that in real time. And from a partnership perspective, this is data that we can share with our healthcare investors. And when healthcare investors kind of invest with us, we're not just kind of promising, that our investments create healthier communities. We're actually providing data on how we're doing that to the populations that we serve. And I think that really forms the foundation of a true partnership, which is, aligned incentives, measurable outcomes, and then really putting capital to work in a way that improves health on multiple levels. I'll pause there.
That is awesome. Thank you. Thanks, Nina, so much. And before we turn to Gina, just a couple of things that I want to note that really struck me, I think. And one is kind of the substantial focus you have on folks at the 60 to 80% bandwidth, that kind of missing middle is a truly big and critical missing middle, I think. And in particular, what I would say is as we think about this from a impact investment perspective, it actually creates ways in which with either no or limited or some government subsidy, you can figure out how to finance housing for folks at 60 to 80% through impact investment, through the type of work that you guys are doing at Catalyst. Whereas, to be candid, I think you have one amazing example, but a lot of times when you talk about folks who are, experiencing homelessness or other things, the likelihood that they're going to need like a government rental assistance is pretty substantial. So there, in some cases, right, the government's going to have to step in, and the market can only do so much. But the market and in the impact investment community can do a ton to help mitigate and reduce that kind of missing middle. So thanks for that. And then I think the other thing really is around the outcomes piece and thinking about like not only, okay, we deployed, these hundreds of millions of dollars, we created X number of units, but here's the impact that we're having both from a resident health perspective and a community health perspective. So thanks for that. And I just be remiss if I didn't say thank you for mentioning that kind of dichotomy in Winston-Salem, because it's probably true in a community that you live in or that is near to you. I live in Minneapolis, and that exact story could be told between North Loop, which is rich and white and in Minneapolis, and North Minneapolis, which is largely black and brown and very poor. And they've done the same little study. Look, it's like basically zero investment in North Minneapolis and billions of dollars in the North Loop. So thank you for sharing that. So,
if one of the wishes that I had on your outcome was, health and housing information cannot be shared. And my wish was always, is there a way to find out how many of my members in my hospital or healthcare members are living in this unit and this facility, and to see the change would have been great. Yeah. But unfortunately, because health and housing can't share that data, it gets lost.
There's a whole host of HIP issues, but also places where I think some folks could think about if they do have resident addresses, kind of,
you can play with
some kind of finagle. So good point. Thank you, Pablo. All right. Next we have Gina, and I'm super jazzed for lots of reasons, but in particular because, I think for a lot of very good reasons, there's a lot of focus on affordable housing and infrastructure and things that we can do to support communities, population health, and the like. And Gina's going to share with us something that has nothing to do with bricks and mortar.
How did I get on the panel?
Yeah, I was going to say, well, we kind of let you slide in, I guess.
Yes, this oddball.
That's right. So we're going to turn it to you to talk about it.
Thank you. And thank you, Andy, for being a great moderator here. So Enable Ventures. We are the first impact venture capital firm with a thesis of closing the disability wealth gap. Now, we just heard from these beautiful colleagues who are telling you about the what, whether it be poverty, whether it be the cycle of economic immobility and how we create upward mobility. And I always I had a great mentor who once said to me, the answer to the what is who. And a lot of our issues are actually deeply intersecting. In fact, I know they are. And as we invest venture capital in the next generation of highly inclusive, accessible technology companies, we're actually intersecting with your issues in a major way, because people with disabilities not only comprise 1 in 4 Americans, but they also currently comprise dual demographic trends that are going to rip through our audience and change all of our lives in our lifetime. And that is, first, that people are now strongly identified with the experience of disability enough that earlier in their life, They're raising a flag and saying, I embrace that I have learning differences or intellectual disability, developmental disability, autism, mobility impairment. And they're saying it with pride. And the second demographic trend, people are living longer. We're in a nation, in an international moment when we have a very low birth rate across the world. And we have an emerging society where people are not only living longer, but they are living right into disability as a result. And so the identification is strong, stronger perhaps arguably than ever before. And strangely, and when I tell you the history, it won't be strange to you, the disability community hasn't really figured out what it thinks about healthcare yet. It has an incredibly fraught relationship with the medical establishment. And in fact, the roots in that have to do with civil rights history. And let me just say that we have 1.5 billion with a B people with disabilities on the planet today. They're super users of healthcare. And yet, historically, what we've done with disability is disability has been othered. Before I was an investor, I was a civil rights lawyer representing people with disabilities, and I worked at the Justice Department for the Attorney General. And we used to see in the 2010s, in the 2000s, exam tables at the wrong height for accessibility in hospitals. We saw people checking into emergency rooms who were deaf, who couldn't get an interpreter, who were in major life crises. We saw doctors that didn't know what autism was. We saw people that weren't conditioned to understanding aging-related dementia and other issues as a disability issue, seeing it as a medical diagnostic. And the history behind that is that we had structured poverty because we had sent people with disabilities away. And we have a long history of institutionalization in the disability community where people were structured physically away from the town square. And I want to emphasize this on this panel, because when we moved people away in order to get care, health care, mental health care, physical health care, away in order to get housing, group homes, psychiatric hospitals, away, we were structuring them physically away from the economy, from jobs, from where commerce was being exchanged, from where goods were being created and designed, where services were being conceived. And when people are away and out of sight, they lose core stakeholder value in conversations about how to design the future. We had a long march towards community integration that really matched the Jim Crow era and movement towards integration with racial justice. But here's the thing, the Americans with Disabilities Act wasn't enacted until 1990. It was the last civil and human rights statute in the canon of civil rights in this country, and it was a predecessor law to countries across the globe. So meaning we were early in 1990, but we were late to the party in terms of healthcare access, in terms of the full realization of rights. But then something else that was truly miraculous started to happen. And that was a technology movement in the United States in our lifetimes that collided directly with the moment that people with disabilities were achieving civil rights for the first time. And we have a generation that we call the ADA generation that only has known post-1990 both civil rights and technology. And they are entrepreneurs. They are conceiving a world that is built without barriers. They're thinking and dreaming and designing technology to be radically inclusive, to exclude the least number of people. And as they think about what they want their technology to do, they're thinking about health. Because they, after all, are the constituency that are super users of our healthcare systems. They also know that they will live longer than any generation before and be super users from an aging perspective. And so what Enable Ventures is doing is we're working with a three-legged stool: healthcare, work, and you all housing, What we know about low and moderate income census tracts in the United States, 60% of people that live in LMI census tracts are people with disabilities. We know, you talked about joblessness, Nina. When we look at 2/3 of working age adults with disabilities are not currently employed. And yet we know that what's conspicuously absent are not ideas or investable technologies, but we have not had capital at the table until now to invest in the truly inclusive products that will bring communication technology into the emergency room, that will bring work tech into people's lives in a way that what we know to be true in disability, and the statistics are absolutely overwhelming, is when people with disabilities work, their long-term healthcare outcomes also concomitantly improve. When people with disabilities have better healthcare outcomes, we know that their work outcomes improve. And so we've had the pleasure of partnering with the most phenomenal partners in healthcare because they understand the interrelationship between health and wealth. And when we look back at the days of segregation, in this country, there was a series of laws called the ugly laws. We outlawed disability. If you saw someone with a disability, it could be a violation for them to be in the town square. We created a spatial distance between disability and commerce, between disability and the mainstream of American life. What we are doing now is reversing decades of segregation with integration. And what we understood in disability is that we had done a lot of work. We did a ton of work around civil rights to get to where we are, where we have reintegrated people into society, but we have also come to a new understanding that what we thought was the other was us all along. What we thought was an other group, a special group, a side alley in the economy, it was always us. And that disability is a topic, but it's also a human experience that we all will have. There's an inevitability to it. But our technology market, much like our early healthcare market since the Civil War, really saw disability until very recently as a lane that required the emergence of point solutions to fix people. And we have had segments like rehabilitation technology, like point solutions in healthcare that have tried to fix disability in the past, who've thought that these characteristics are things that we need to plan for, control for, and blot out the basic character of disability for better medical outcomes, better economic outcomes, better healthcare outcomes. What we're learning from this ADA generation that are looking for radical integration in tech is that it's the rest of society that can benefit from the value that's being driven by people who design for all from the beginning, who think inclusively, who are looking at the hardest parameters, the most difficult design constraints. How do I get 99% accurate real-time transcription technology for people who are deaf and hard of hearing, who want to understand what their doctor is saying to them and not fail them? How do I get that? And what we found is some of the most emerging leaders in tech are the people that are saying, I'm not going to avoid the difficulty level of that problem set, but I'm going to run straight into it, solve it, and convey the value of a 99% accurate transcription technology, then in turn to people who are dyslexic, who need a better note taker, to people with short-term and long-term memory loss who need a note taker. So it becomes an all of society value creation, the solution. And that, most fundamentally, we're seeing that time and time again. We're also seeing emerging solutions that we should have had years ago. You scratch your head and, you all think that I would come up here and talk about the most dazzling healthcare solutions that are going to revolutionize treatment. But you know what? We couldn't get into your hospitals because the door was inaccessible or the pavement was irregular. And we have a company in the Enable Ventures portfolio. Years ago, departments of public works need to take a ruler, a level, and a balance and go out to the sidewalk. And with the poor, scrappy team in local municipalities would have to see which of the sidewalks were irregular for wheelchair use. They would rinse and repeat. They would do this on a regular calendar schedule. We just invested in a company that has done 80 cities using LiDAR and computer vision, has a algorithm that is geared towards ADA sidewalk public rights of way standards, scans the sidewalks at scale, can do it within a very, very short amount of time with significant cost savings. And you'd say, well, what the heck does that have to do with healthcare? How can we serve people if they can't get in the front door? And this is about that idea historically that we did not have people with disabilities in the town commons for many generations. And now we are there, we're the final mile of radical inclusion, and we can solve that final mile. We do have solutions at scale that can tell us how to fix the sidewalk. We do have communication solutions that can make communication more effective so that healthcare can get more effective. We have a platform that is solving a radical problem with community health workers. There are people that have informally across the United States been the final mile of healthcare for people with chronic conditions, people aging in place, who've been outside the ambit of the front door of the hospital, of their treating physician, of their clinician. How do I get in? I don't know where to begin. I can't navigate. How do I find my way? And those are traditionally, in a major way, people with disabilities, people with chronic conditions, people who are aging. And the government created a billing code for community health workers. The only problem is that it is a highly fragmented system that nobody knew how to pull down the code, how to take an informal, powerful labor supply and organize it. And a company, PearSuite, has centralized a billing platform for that amazing army of final mile healthcare workers to bring people who are highly vulnerable and left out back in. We know that tech can create radically simple solutions. In fact, the simplest solutions are the best. And the disability community is being reached through many of these tools because the people who are designing them are closest to the problems that they're trying to solve. In fact, we are on a hunt for people with disabilities who are building tech right now all over the world because they're closest to understanding that final mile, understanding the barriers that they're confronting.
Awesome. So thanks so much. Well done. As always, awesome work. And I think this is on, but so thank you so much. And I think, hopefully we're going to jump to questions and discussions here in 1 minute, but just want to say, hopefully you guys got a flavor, a bit of kind of the healthcare perspective of the value proposition and the like. And what was exciting to me, at least when we were starting this conversation, was Nina being able to talk about, here we're building housing and clinics, and here's how this impacts and connects to healthcare and why healthcare investors might be interested and engaged. And here you have somebody who's not doing anything about building housing. There's a connectivity to it, but is substantially focused on the disability community. And and shout out to groups like United, who I know invested in them a couple years ago.
Big shout out. Big shout out.
That's right. And others, though, right? And thinking about the number of people that a payer like United or a provider that is serving. In a hospital system that Pablo is working in, what percentage of people have disabilities, right? And so just to go back to where I began, when we start talking about, the opportunity to match private capital, impact capital, with solutions that Nina's and her team have, with solutions that Gina and her team have, really creates an opportunity for us to kind of figure out where there's a healthcare proposition, value proposition. Sorry about that. I'm usually loud, as a few people know. But no, so I think, and understanding where then there's that connectivity between how and what these impact investment folks are doing and how it relates to the mission and the value propositions and the others of healthcare stakeholders kind of across the board. So So thank you, panelists, for that. We have about 15 minutes, so we actually, not too bad for the moderator. Sometimes people say
You're on the
1 minute
nose.
left,
Yeah, no,
right?
perfect.
So, see, I got a kudo from that young man. Thank you. All right, let's go ahead and open it up. I know we can share one of ours, maybe. I don't know how far it goes, but we got a mic right there. So we'd love to welcome questions, comments, and anything anyone wants to share. Yes, sir. You're first.
Hello, good afternoon, everyone. Thanks for this inspiring session at the end of SOCAP. That's great. Yeah, look, they resonate. So my name is Santiago Torres. I work with Tech to the Rescue. We're a global platform that enables impact organizations with technology and AI. And my question is to you, Regina. I really love the way you are vocal and about the people you serve. And we'd be happy to connect and see how we can develop these AI and tech skills, these tech capacities in different countries. Maybe share the stories that you have just shared with us, and hopefully create those use cases about how AI can be on the positive side, right? We are AI optimists. So more than a question, is a comment, but yeah, that would be basically it.
I'll make it into a question. Okay. Gina, tell me about your portfolio. How many companies do you have that use AI? Great question. And I do want to meet with you afterwards. But I think it's like you hit it on the nose, because people, there's a lot of false equivalency rolling around about you can do impact or you can be working in AI. We do both. And I'll give you an example. We've invested in a company called Be My Eyes that's had millions of people use the app. Nearly 9 million people have interacted with the app. 1 million, over 1 million blind user experiences. And it is using computer vision. It's an LLM that was trained with blind cultural competency in order to narrate the world with particularity to blind people. And, in another lifetime, I was the outside general counsel to the National Federation of the Blind, a 50,000 blind person coalition and organization. And I knew brilliant people that were members of the National Federation of the Blind who had PhDs, who had JDs, who were just genuinely brilliant. But it didn't matter. When we went to dinner, I read the appetizers and the entrees and the desserts so that they knew what was on the menu. When I go to dinner with anyone today in the world that's blind, they inevitably have access to Be My Eyes, and the computer vision is reading the menu for them out loud. And so when you're thinking about what is the culture shift that AI created there, it's massive. It is epic. It is giving people their agency back. Now, I told you about the menu. Take that into the workplace. The blind friends that I have are always doing an estimation, a calculation of social capital. They are constantly perseverating about whether to ask a colleague about whether the cable in the back of their computer is loose, or how many paces the concessions have moved in the office. Is there a new coffee cart, right? Like these little social estimations of space and understanding that actually might yield negative, adverse consequences in employment. And what we're seeing when Be My Eyes is taken into the office, there's this whole other inestimable, perhaps incalculable, social capital and economic mobility that is happening because people have agentic AI, but an attachment to a solution that gives them their anonymity back. They are not giving anything away to ask a question of an AI agent. And what's absolutely amazing is that the amount of people that have said, if you take this away, I've even had a United States federal judge using Be My Eyes that said, if you take this away, I don't know who I am without it, because I have adjusted my lifestyle to using this tool. And so when we talk about centering the human experience and AI, You cannot find, better, in my estimation, better exemplars of meeting truly human and urgent needs with these new advances in artificial intelligence and creating deep and rich impact.
Great, thank you. And I think just to also share, I mean, I think we had talked about the fact, right, how much sense it makes for healthcare organizations to think about partnering and investing in groups like Enable. One of the things that I'll just say that I've learned from Gina over the years too is also not only the number of people with disabilities who are going in and out of Pablo's hospitals or within managed care or others, but also how many of these technologies and other things end up being applicable across the board. Kind of, I recall one of your past colleagues kind of talking about the fact of like, if you solve for the hardest part, you can solve for everything. So, so thank you for that. Next question, yes, ma'am.
Hi, I'm Jamie. Can you hear me?
Yep.
Okay. So I'm Jamie White from IH Strategies and also representing Business 360. It's a question specifically to you, Regina. Actually, no, not Nina. Sorry about that.
We were going to have a Tina and a Pina, but we just didn't get around to it. But Nina and Gina.
Yeah, there you go.
Did, did you say healthcare 360?
Oh, so IHS Strategies and also Medicines 360.
Okay.
Yeah. So I'm curious for your program. You talked about that a lot of times people now have more money to invest, but oftentimes I would assume those communities don't know where to invest. Do you help that? Do you help them with financial literacy or where to invest and how to invest?
I love that question so much. Yes and no right now, but it is on our horizon. Like I mentioned before, we try to program our ground floor commercial spaces to meet the needs of the community as much as possible. And so we do have examples in the books of ground floor commercial spaces that have community credit unions in the ground floor. And those community credit unions were programmed there specifically because that community lacked access to financial services. And we chose the specific community credit union because they were very focused on education. And we actually were able to build out that ground floor commercial space in a way that reserved a huge portion of the space for an educational center. And what is really exciting about that is we're able to then kind of collaborate between that credit union and then our tenants upstairs and ask them very explicit questions around what areas of financial literacy are you interested in learning more about? Is it homeownership 101? Is it starting a business? Is it building your credit? And then we're able to take those survey responses and work with the credit union in the ground floor to craft kind of an educational program for the year. And then we're able to work with the community credit union to then report out on, attendance in those programs, number of kind of new savings and deposit accounts that were established. I think there is a way to programmatically do that across our portfolio, which is something that we're hoping to roll out in the next, I'd say, year or so. That would offer that more broadly across our kind of swath of investment assets, not just specifically in the assets that have, community credit unions in the ground floor. That would be through, I think, really partnering strategically with our property managers around programming for that community and using our community convening spaces. Many of our buildings have community convening spaces in them, using those spaces for programming, right? Whether that's bringing in a local nonprofit that focuses on financial literacy, right? To do programming for that community. Or maybe that community is more interested in, learning how to cook healthy food, and you could bring in, a program focused on that. So we are really working on figuring out how to tailor the explicit needs of each resident base to then the programming that we put on, not just in the ground floor through commercial tenants, but in our commercial spaces or in our community convening spaces through our property managers. So it's on our horizon, yes.
And I think what's great, and people get ready to raise your hand for the next question, but I think what's incredible about that too, when you guys are doing literacy programs or helping with clinics, right? The residents are beneficiaries, but the whole community benefits, right? So if somebody's doing a development and they're figuring out, okay, we're going to do affordable housing and we're going to also co-locate a clinic, or we're going to co-locate a bank and financial literacy or credit union, right? It's an asset to the residents, but it's also a much broader kind of community asset for thousands of people in the community. So thank you.
Time for a quick one.
We'll go with this gentleman, and then we will wrap up, sir. He said one.
Thank you. Dan Wexler, Eat Well Meal Kits. Sorry, this might be not a quick question, but I guess we can answer it quickly. It's maybe a little more abstract. We heard about financing health systems, about building affordable housing, accessibility for populations. These are predominantly infrastructure challenges, right? These are social determinants of health. What does that suggest about the U.S. healthcare system and the systemic changes that are needed?
That might be a bad question or a good one. What did you say? I couldn't hear you at the beginning of the question. Oh, a short one. Okay,
Yeah,
okay.
yeah.
Yeah, that's definitely a long one.
So, Pablo, if you want to, I think, to me, what I would just tell you is more of kind of a societal question, right? About kind of the priorities that we have and set in our country, and what not only our health systems do, but what our governments do at the federal level and state level, right? Those are where largely the actual initial starting point for these resources. So it's not to let anyone off the hook or to put accountability anywhere. It is just to say that to me, I think it is, you need to be able to look at that kind of vertically and horizontally, right? Vertically from the perspective of you have federal government, state government, county government, and then you have payers, and then you have providers, and then you have clinics and mom and pop shops. And then across, right, we have healthcare, we have affordable housing, we have accessibility issues and the like. So, I will let others weigh in, but I think it's a broader kind of conundrum for our country to take on that literally goes public and private, goes up and down the chain of levels of government and across the axes of these social determinants of health or where, why, we have SNAP going out now, right? So where are we thinking about food security? So it's not only the verticals of the government and the private sector and philanthropy, but then the horizontals of affordable housing, of transportation, right? Our transportations are entirely designed poorly for little companies, so and the like. So.
I also would, I'm sorry, Pablo, you go ahead. You go ahead.
No, go ahead.
Really? Oh, really, go ahead.
So this is where I get thrown off the island.
I was trying to keep us all on the island together, Pablo.
My concern with healthcare and it's turning everything into the responsibility of healthcare. With healthcare costs going up, yet when we talk about housing, it's a healthcare issue. So it's up to healthcare now to fix the housing issue. So it feels like the can is being kicked up the street for healthcare to pick up and do something with it. Access to food. Yeah, that's a healthcare issue, but it shouldn't be passed on to healthcare to pick up the issue. It should be, put together.
Food delivery system.
Yeah, working within the community, within the government, with the local, state, and federal, but also with the individuals in the community as well. But yeah, this is where I get a little.
Gina, you get the final word unless you have.
He's waving wildly. Go ahead.
Gina's happy to speak.
What I would say is the technology market has allowed us to solve once in 100-year problems that we might not have been able to solve 5 years ago. That's how rapidly technology and AI are developing, and all to the benefit of long-term healthcare outcomes. And so I come with great optimism, having been a reformed litigator that saw only problems everywhere I looked. Now I only see potential solutions. And I think that creates a generational shift in healthcare that we haven't even begun to feel.